Good evening, everyone, and welcome. Thanks so much for joining us for this virtual UMiami Health Talk, Innovations in Structural and Valvular Heart Treatments. I'm health specialist Ileana Bravo, your moderator for this evening's webinar presented by UHealth's Cardiac and Vascular Program. The UHealth Cardiac and Vascular team offers cutting-edge structural heart innovation. Our program has led the way in developing minimally invasive solutions to treat patients with complex heart conditions. Our specialists excel in the most advanced catheter-based procedures and minimally invasive surgical techniques, addressing the full spectrum of heart disease. We provide patients with access to the complete array of FDA-approved percutaneous therapies available today. Multidisciplinary care by a recognized team of experts and specialized programs for heart disease prevention. Please learn more about UHealth's cardiovascular department at umiamihealth.org/cardiovascular. Schedule a consultation and screening. Please call 305-243-5554. No worries. We're going to put that information up again at the end of the talk if you want to take a picture of your screen so you'll have it with you. And we're also going to send you this talk for all of you registrants afterwards in about a week's time. Anyway, tonight our panel of experts is going to discuss the latest on percutaneous heart valve innovations, minimally invasive procedures, and treatments that benefit patients. Here are some of the specifics we're going to cover. Aortic stenosis and transcatheter aortic valve replacement, also known as TAVR. Mitral regurgitation and minimally invasive procedures. Left atrial appendage occlusion and procedures. And how LAAO, which is what that procedure is called, fits into the broader strategy for managing Afib. And at the end of the presentation, there's going to be a Q&A session. This is a unique opportunity for you to ask direct questions of our experts, so please take advantage. Take a look at your screen. It's the Q&A feature at the bottom of your Zoom to enter your questions, and we'll prep them for our panel. All right, now let's kick off our talk tonight with the Division Chief of Cardiovascular Medicine at the University of Miami Miller School of Medicine, Dr. Yiannis Chatzizisis, an internationally recognized board-certified interventional and imaging cardiologist. Dr. Chatzizisis, take it away. Let's kick this thing off.
Thank you so much, Ileana, for having us here tonight. We're very thrilled to run a very interesting educational webinar. And as you said, we have a group of world-class experts from our division to discuss about a very hot topic, which is the structural heart interventions. I would like to spend the next couple of minutes with a very short introduction on about our division, about the Division of Cardiovascular Medicine, starting with our strengths. First of all, we have a visionary leadership at the UHealth system and, of course, at the medical school, Miller School of Medicine system. We operate with skillful faculty and staff, and this makes a difference. We operate in world-class research centers and institutes. We have access to an extensive clinical and research infrastructure. And of course, we are under the ecosystem, the umbrella, if you want, of the University of Miami. And what is our healthcare system? As you see here, it's quite wide, and we serve the entire Tri-County area from Miami-Dade to Broward and the Palm Beach County. We have the UHealth Tower, which is the Mother Institute here downtown. And then we have multiple multi-specialty medical centers across the Tri-County area. And I would like to put emphasis on the Lennar Medical Center South, the Doral West, which just opened, and we're very thrilled about this. And of course, the Solemia Medical Center, which is going to open the gates later in the summer of 2025, along with other smaller multi-specialty medical centers. But the essence here with this wide healthcare system is that we help the community at the neighborhood. The experts, the cardiovascular experts, go at the neighborhood instead of the opposite to make it easier for our patients or our community to have access to our services. And then we maintain the main tower only for advanced diagnostic or therapeutic procedures. And this way we serve the community in a more seamless and efficient way. What is our mission? First of all, to offer the finest clinical care across the board, to perform world-class research and bring innovation, to provide to our trainees excellent education and training, to integrate digital technologies. We envision the University of Miami Division of Cardiology to be a hub of technological innovations, and we emphasize on digital technologies, and of course, to collaborate with academia and industry to stand out at the end of the day, regionally, nationally, and internationally. And speaking about clinical care, I would like to emphasize that we operate with multidisciplinary clinical programs from prevention, diagnosis, to therapy of cardiovascular disease. And we emphasize on top-class quality and outcomes and innovation. And this triplet of programs, quality, outcomes, innovation, is what helps us grow clinically and academically. With regards to the clinical programs, as you can see here, we cover the entire spectrum of cardiovascular disease. From prevention, we have probably the only academic comprehensive preventive cardiology program in the area, where we have access to nutritionists, to hyperlipidemia experts, to experts on hypertension. We have the among the very few in the country AHA certified hypertension centers, and of course women's health. Coronary disease, very, very important priority for us, all the way from prevention to diagnosis with new advanced diagnostic methods, and of course advanced therapies, including complex interventions and surgery. Valvular and structural heart disease, which is the topic of the day, offering the latest diagnostic methods, specialists on how to diagnose and how to treat percutaneously and surgically those valve and structural abnormalities. Aortic and peripheral disease as well, electrophysiology programs, and of course, heart failure, which is the pinnacle of cardiovascular medicine. And of course, today, we're going to focus on valvular and structural heart, and you'll have the opportunity to hear more about that. And finally, I would like to highlight a couple of innovations that test how well the whole operation and how much we serve our community. We have been the first academic center in the state of Florida that applied lately a drug-coated balloon, a new innovation that helps patients with stenosis. In the field of structural heart, we've done, as Dr. Spilias will show to you later on, the first same-day discharge in Florida after a TAVR operation. And of course, in the field of hypertension, we've done the first renal denervation procedure to help patients with uncontrolled hypertension in the state of Florida, and among the first in the whole country. So to summarize, we're here to offer top-class quality, to offer unparalleled patient care, to offer first-class education and training to our trainees, to perform first-class research and bring innovation, and at the end of the day, set the standards for quality and research and innovation regionally, nationally, and internationally. Again, thank you so much for having us here tonight, and we look forward to the discussions by Dr. Spilias and Dr. Cox.
Thank you so much, Chief. That was great overview, and the fact that we've spread out UHealth in this community from one end to the other, Dade, Broward is really something, because it goes right to the neighborhoods, and that means a lot. So let's kick up our next speaker, which is Dr. Nikolaos Spilias, an interventional and structural cardiologist who specializes in catheter-based, minimally invasive procedures for the treatment of coronary artery disease and heart valve disorders. His goal is to provide world-class, top-quality care for patients with coronary artery disease and valvular heart disease. Welcome, Dr. Spilias. Take it away.
Thank you. Thank you very much. Good evening, everyone. Thank you very much for joining this evening, this very interesting and educational webinar. I would like to talk to you about aortic valve disease, and more specifically, aortic valve stenosis, and how we treat it nowadays, and more specifically at the University of Miami. First of all, I would like to start with the basics. So what is aortic stenosis? And what is structural heart disease in general? So structural heart disease refers to any disorders that affect the structures of the heart, as the word implies, like the valves, the walls of the heart. And here you can see what the normal heart valves look like. This is the aortic valve, this is the mitral valve, this is the tricuspid valve. So the valves are like doors that open and close and allow the blood flow only in one direction. So as you can imagine, we can have two possible problems with a door. One is that it's not opening all the way, it's not opening very well, and that makes it hard for someone to get through if the door doesn't open well. And the other problem is if the valve doesn't close well. Like when the door doesn't close well, then we can have like, wind get through, or humidity here in Florida, or, especially Miami. So this is the aortic valve that opens and closes with every heartbeat, and it allows the blood to flow from the heart into the aorta and the rest of the body. Here's an example. That's the short axis, let's say, of the aortic valve. That on the left side of the screen, you can see what a normal aortic valve looks like with 3 leaflets, how it's opening. And on the right-hand side, you will see again a valve that has a lot of calcium on it, and it doesn't open well. It doesn't open all the way, and that makes it harder for the heart to push the blood into the aorta and the rest of the body, as you can see here. So there are different degrees of aortic stenosis. It's a progressive disease. We have mild, moderate, and severe. About 12% of the population older than 75 has some degree of aortic stenosis, and the degree of the percentage of severe aortic stenosis is estimated about 3 to 4% in this population. So what are the symptoms of aortic stenosis? These are the main symptoms. I would say the most predominant symptom is shortness of breath or chest discomfort, especially with exertion. Easy fatigue. People sometimes can feel dizzy or lightheaded because of decreased blood flow to the head and to the brain. They can also get swelling in the legs or other parts of the body, and fluid in the lungs, which can cause shortness of breath. So how do we diagnose aortic stenosis? I'm sure many of you have heard the doctor saying, oh, you have a little murmur. So what is really a murmur? So let me play this video here so you can hear actually what a murmur sounds like. So what we hear when we say, oh, you have a murmur. So you can hear the sound of, so this is like the sound that the blood makes when it flows through a valve that does not open very well, and it makes this noise. So the next step when we hear a murmur is to do an echocardiogram or an echo in order to see the function of the heart muscle and also the function of the valves. So this is I would say the cornerstone for the diagnosis of aortic stenosis. And the CT scan is also playing a very important role in the diagnosis of aortic valve disease, and especially it's very useful for the planning of the procedure of the aortic valve replacement. So if someone has mild to moderate aortic stenosis, then surveillance is recommended every 6 months, every year. We do another echo to check. And if someone has severe aortic stenosis with symptoms or reduced heart function, then aortic valve replacement is recommended. So what are the ways to deal with the problem and replace the aortic valve? There are 2 ways nowadays. One is the transcatheter aortic valve replacement, or TAVR, which is a minimally invasive procedure. And the second, more traditional option, let's say, is the surgical aortic valve replacement or open heart surgery. The first TAVR procedure was performed in human in 2002, and it's become so commonly used since then that in 2019, actually, the annual number of TAVR procedures exceeded the number of surgeries for the aortic valve disease. So nowadays, there are more TAVRs performed for the aortic stenosis than surgeries. So what is TAVR or transcatheter aortic valve replacement? So it's a minimally invasive catheter-based procedure for the replacement of the problematic valve. And that's a bonus point, and I'm going to show you. If someone has already a surgical valve in place in the aortic position, we can do the valve replacement again through the groin. So put a new valve inside the old surgical valve. It's called a valve-in-valve procedure. It's performed under moderate sedation, not general anesthesia. And the new valve is inserted through a very small incision in the groin area, through the femoral artery. The procedure usually takes about 1 to 2 hours on average. And I want to show you this animation now. So this is the valve going in through the groin. We have a wire from the groin all the way the aorta and through the heart and through the aortic valve. And you will see how the valve is collapsed and it has a balloon inside it, because that's the easiest way to insert it in the body. It's collapsed. And then we advance it through the aorta. We're using X-ray to visualize the valve and the aorta during the procedure. And you're going to see how carefully we are advancing the new valve inside the old valve that does not open very well because of calcium. And once we're in the right place, then we inflate the balloon, which you're going to see now. We position the valve, in the right place, and then we're going to inflate the balloon. And the valve will show the zoomed function there, how we can move it in and out and position it exactly where it should go. And then we inflate the balloon, and the new valve pushes the old valve to the side, and it takes its place and functions. So then we're going to remove our equipment, as you can see, again, through the little incision in the groin. And this is now how the new valve looks, right in place. And it's opening and closing, and you can see how well it's opening. So this is just a very quick animation of how we can do the same procedure if someone has already a surgical valve in place. Again, the same concept. We put the new valve inside the surgical valve, and we inflate the balloon, and the new valve is pushing the old valve to the side, so it's wide open, and it takes its place. The same concept. The new valve is inside the old valve, and it's doing the same job, like that. So this is actually, a real case from University of Miami done earlier this year. You can see here on the left-hand side, the artery we're using in the groin. We're injecting contrast, and we use X-ray. So we're going to put the valve through this artery. This is the actual valve deployment. X-ray, that's contrast in the aorta, and we're inflating the balloon. And this is the new valve as it's expanding in the aorta. And on the right-hand side, you see the final result after we remove our equipment, how the valve stays there. The valve gets anchored on the calcium, and it just stays there. So what is the expected recovery after this procedure? So usually the patients have to stay in the bed for 4 to 6 hours, so the groin heals well and there's no bleeding. The patients usually stay in the hospital for 1 night for observation, and they go home the next day. They may experience a very mild bruising or tenderness in the groin area where the valve went through. And we usually advise the patients to avoid any strenuous activity or lift anything heavy for about a week. And of course, we see all the patients within 3 to 4 weeks after the procedure. And actually, what I want to add here is that there's a dedicated phone number that the patient and their families get after these procedures, and they can reach out to our team at any time during the day if they have any questions or concerns after the procedure when they're at home. So there's a dedicated phone number that they get. So what about the safety of the procedure and the risks? So TAVR is a very safe procedure with great outcomes. And the outcomes of TAVR are at least equal or even better in some cases than surgery. So the risk for a serious complication is about 2 to 3%. And there is also a small risk of a pacemaker need after the procedure. It's about 5 to 8%. So another point I would like to emphasize that here at the University of Miami, we use the latest technologies powered by artificial intelligence. And this is a simulation of the valve placement in the aorta of a patient based on their CT scan. So we reconstructed the patient's aorta, and we simulated what the valve will look like when we put it in place, and how exactly it's going to sit and perform. So, and this is from a case we did. You can see how, similar, almost the same, the model looks with the actual procedure we did, the position of the valve, the size of the valve, and this contributes to individual procedural planning and patient care. And this is our goal. We treat every individual differently. Every individual is different, and we prepare for that, because our goal is to give the best possible results for the individual patient, because everyone is different and things can change. And I would like to share here one of our achievements earlier this year. Again, this patient had the TAVR procedure, and she was discharged on the same evening. So she came in the morning for the procedure, and she went home the same evening. Everything, was checked. This was, very safe. She had a very supportive family environment at home. So she was discharged, went home. The recovery was very smooth, and then she came to see me in the office after the TAVR procedures, you can see, with her daughter, and we took this picture, and we shared the story a few months ago. And this was the first same-day discharge in South Florida. So I just want to emphasize that we have a heart team. We operate as a team. Our team has interventional cardiologists like me, Dr. Cox, Dr. Chatzizisis, cardiac imagers, surgeons, and we all meet once a week, and we discuss every case, and we determine what the best treatment for every patient is. So we operate as part of the team, and that's what we take pride in. And thank you very much for your attention, and we can move on with the webinar.
Thank you, Dr. Spilias. Amazing. Same day. That we've gotten to that. The future's here. All right, there are a lot of you asking questions, and we want to keep this interactive audience participation going for our Q&A session. And our expert physicians are going into the Q&A box and answering some questions directly. So we're very fortunate tonight to have that. So let's move on to our final speaker tonight, who is Dr. Pedro Cox, the medical director of the Structural Heart Valve Program at the University of Miami. He's renowned for his interventional cardiology and structural heart disease specialization, with clinical expertise on the percutaneous management of complex coronary and endovascular intervention. Let's welcome Dr. Cox.
Hi, good evening, everybody. Thank you, Yianna, for hosting this event, and thank you, everybody, for logging in. Nico, and great presentation. Today, I'm going to be talking about left atrial appendage occlusion. We're going to be discussing a little bit of why we use it, why it's important for us to understand its use. We're going to be talking about its indications, a little bit of the procedure overview, and recovery and follow-up. Okay. So first, I'll start with the issue of atrial fibrillation, which is an arrhythmia that by 2030 is expected to have 12 million persons with atrial fibrillation in the US, epidemic proportions. As we know, atrial fibrillation increases the risk of stroke by 5-fold. 25% of ischemic strokes are associated with atrial fibrillation. And the main therapy for prevention of stroke in this population are blood thinners. There has been more than 250,000 implantation of this left atrial appendage closure worldwide. So nowadays, it's very known and becoming very popular. So what is atrial fibrillation? So we need to understand that in the upper chambers of the heart, sometimes it can beat fast and irregular. Instead of beating steadily the heart tends to flutter, which can cause the blood to pool and form clots. You have to imagine the heart like a drummer keeping a beat. Atrial fibrillation is like a drummer that gets confused and starts playing in all over the place. So that will it's atrial fibrillation now. Atrial fibrillation is dangerous in the way that the company it keeps its stroke. So it has again a very direct association with the stroke. And the issue is that these bloods with that irregular rhythm sits too long in the atria. It tends to form clots. When these clots break off, they can travel through the blood from your bloodstream to your brain, creating a blockage, and this blockage can cause a stroke. And we know that 90% of this stroke come from the left atrial appendage. And what is the left atrial appendage? This is it's basically a pouch, a small pouch that's located in the upper atria of the heart on the left atrium, which is again like a little pocket, a little room to the side of the heart. And this is where these clots come from. We have known for a while that oral anticoagulation is important in treating and preventing this in people with atrial fibrillation. And there's some clear recommendations for us to give our patients regarding oral anticoagulation. However, some patients have issues taking blood thinners, and this can be because they have bleeding issues, or they have fall risk, or they cannot tolerate the medication. And is in this population that left atrial appendage occlusion was studied and proven to be an effective therapy. And what we're talking about is a therapy where we can go inside the heart, inside this pouch, and seal this area of the heart so that you can have a lifetime prevention and reduction of your stroke risk in patients that have atrial fibrillation. And again, this is a permanent implant through a minimally invasive technique, which can be done very safely in the hospital. So in regards to what we have studied, as we have heard in the TAVR space, here in the left atrial appendage, also we have seen more than 20 years of experience, not only while doing research, but also in the commercial side, doing the procedures with studies that have shown clearly the safety, as well as how the positive impacts in comparison to blood thinners with the left atrial appendage occluders. So it's a very effective therapy that we can offer our patients. In terms of safety, again, to mention, I would say that 98.8% of the patients have successfully been implanted, and this is data from commercial as well as clinical trials, with a very low event rate and issue with complications. Okay, I have to mention that not only having a bleeding episodes, it's an indication to think about therapies to close permanently the left atrial appendage, but there's other people that can benefit. Like, for example, people that have documented poor compliance with oral anticoagulation, people that have the inability of maintaining therapeutic levels of blood anticoagulation in the bloodstream, people that are intolerant to these warfarin, coumadin, or the newer anticoagulants. Those patients that have high risk for recurrent falls, patients that have renal failure or have a cognitive impairment. Or you can have a patient that has an occupation-related high bleeding risk. And then you have people that they prefer not to be on oral anticoagulation, and they are looking for other therapies to prevent stroke from happening. So the procedure overview, this is a procedure that we do in the hospital. The patient undergoes a thorough assessment, which includes imaging and blood test. We definitely need to discuss risk, benefits. The procedure is done in the cardiac cath lab under either general anesthesia or moderate sedation. We typically perform the access via a catheter in your leg, in the femoral vein. We visualize and navigate the heart through X-ray and ultrasound, and we use devices that can be deployed in the left atrial appendage. And these devices are made of a mesh material that allows tissue growth over time to this appendage. After we deploy the device, we make sure with imaging that we have the proper placement and sealing of the device of the right atrial appendage. This is an animation of the procedure. As we can see, this is a catheter going into the heart and finding and navigating through the heart into this pouch that I call the left atrial appendage, and deploying a device, in this case, sealing off this pouch inside the heart. This procedure, patients typically stay overnight for monitoring, or they can be discharged same day. Some may require short-term anticoagulation post-procedure for 45 days until the left atrial appendage is fully sealed. We follow up this patient recovery process. We reassess the device effectiveness, and most patients can resume their regular activities within a week. So what type of candidates are we getting now? The candidates that we're getting now are likely secondary prevention of people that already had bleed. Now, however, we're seeing more and more the patients that actually are either they had a fall, or they are at risk of falling, or they're frail, or they have an issue with the blood thinners, or they don't want to be simply on blood thinners to begin with. So I think in the future, we'll be seeing more and more of the primary prevention for the occlusion of the appendage, rather than seeing patients that already had an event, and because of that, now they cannot be on on blood thinners. So again, the indications, again, it is to reduce risk of stroke in patients with a non-valvular atrial fibrillation, and then obviously in people that are seeking to other alternative to blood thinners to treat and to prevent strokes in this arrhythmia. Now, I have to emphasize that here in University of Miami, we have a team eager to not only treat and follow and give options to patients with aortic stenosis, atrial fibrillation that need some type of prevention of stroke. But this team is full of specialists. This is a multidisciplinary team that assess these patients. I have to say multi-professional. You know, we have cardiologists, CT surgeons, we have advanced imagers, we have anesthesiologists, coordinators, a research team that's eager to help any of our patients to tackle these issues. We definitely offer other therapies within the heart that to treat holes and other valvulopathies in the heart, like for example the mitral H2H repair, the minimally invasive mitral valve replacements, the issues in the other forgotten valve, that's the tricuspid valve, as well as holes in the heart, either acquired or congenital holes that we need to close because of issues in the pump failure or stroke arrhythmias as well. So we definitely are a group eager to help eager to treat our patients with the most utmost technology and provide an exceptional care to the community, to the state, without exception. And with this, I will conclude my part of the presentation.
Thank you, Dr. Cox, and that was great. The audience is jumping in with lots of questions, so it's a perfect time to start our Q&A session. Are you two ready to take them? I'll bet you are. All right, so a few things jumped out, and I saw following the Q&A chat, questions such as, what materials are the valves made of? Are the valves forever? We know that stents have a life. Do valves have a life as well? Whoever wants to take it.
Yeah, I'm happy to answer this question. So there are two main types of biological valves we use for TAVR. Cow tissue and pig tissue, so bovine or porcine as we call it. So the frame of the valve is made of like metal, it's metallic, and the leaflets inside are made of cow or pig tissue. So the duration of the valve, the lifespan of the valve on average is about 10 to 12 years in some cases. That's the average lifespan of the valve. And as I said, when this valve goes bad, we have always the option to put another valve inside that valve that we already placed, if the anatomy is appropriate and if the size of the valve is appropriate.
Okay, Dr. Cox, this one is for you. And we have a lot of other questions that we're just going to go through them as quickly as we can. But what do you think of chelation for coronary artery disease? This person says they've seen research that claims it has some effectiveness. Chelation, other medications for coronary artery disease to sort of nip it in the bud, to reverse it?
Yeah, I'm not that familiarized with chelation. I do know that there is some research out there for actually a long time, since for more than 30, I mean, in the 80s, I would say, and more. And I do know that there is some specialties, some doctors actually in the community that have some expertise in this subject. However, I do not know that they have panned out in a way, in significant way in clinical trials as to be a mainstream in the guidelines or indication for any of the things that we treat. I'm pretty sure that we're going to be seeing in the future more and more of this. There's more to say. There's so many things that we don't know yet. And we have to be open to the fact that this might, change the game at some point. I think that, in terms of giving patient recommendations regarding chelation, I would say, talk to your cardiologist, talk to your primary care physician to see if they have more information on this subject. I have to say that if you're going to be thinking about this or talking about this, there's some people here in the US and actually in town that can talk to you about chelation. This is not my subject, but definitely you need to get the right opinion from an expert so that they can talk to you more about it.
Okay, fair enough. So how about, we know ablations have been successful in dealing with Afib. So this one is pulse field ablation compared to your LAAO procedures or something like that. Is that an alternative, an option?
So ablation is treating the arrhythmia per se, right? Here we're trying to treat the mechanical part of the clots that are forming inside the heart, and we do have some great electrophysiologists here, Iliana, as you know, the group of Dr. Mitrani, Dr. Lambracos, Dr. Velasquez, that are great electrophysiologists that treat atrial fibrillation with all these technologies, including actually the left atrial appendage, but also the part of the ablation, which is a very technical point here. And then again, ablation is becoming a more and more common procedure. The success rate is becoming better and better. And these alternative and actually treatments and engineering and the devices that they use are getting way better. So I think that's a great question. And I think that, again, an electrophysiologist like the ones that we have here can definitely help sorting out this issue with each of the patients.
Yeah, and I'll remind the audience that the phone numbers that we've given and the website and all that, that's your resource to get to all of these experts and this entire team. So don't forget about that. We can't answer all your questions tonight. And really, the experts in some cases have to see you and have to review your medical files in order to give you the right answers. One of you had said in your presentation that you might need a pacemaker after one of these procedures. Why is that? I think Dr. Spilias.
Yeah, so the TAVR procedure, and I can share my presentation real quick again, so I can show you exactly why that can happen. So right here, if you can see my screen. Okay, so let me pause it there. So if you see my screen, so right here, this is where the electrical cables or the conduction system of the heart goes through, right inside the muscle, like on the back here. So when we inflate the valve and we put it there, if the valve touches or pushes a lot on the electrical cables there, it can injure them. It can injure those cables, and sometimes this injury is just transient, meaning that you may have, people may have some bradycardia for a few minutes or hours, and then it goes away. But sometimes it can be permanent. So the key to prevent that issue is to implant the valve in the right depth. And we have great control of that during the procedure with the techniques we're using, with the X-ray, with the contrast, and also with the simulation that I showed earlier. So we know exactly at what level and what depth we put the valve, so we prevent this issue. So the rule is the deeper the valve goes, the more likely that these electrical cables will get injured. The higher we put the valve at a safe, obviously, depth, height, the lower the risk. And our pacemaker rates, so nationally, it's about 8 to 10%. And University of Miami, it's much lower than that, because we use the proper technique in making sure that the valve is not placed very deep to push on the electrical cables.
Okay, thank you. Thank you for bringing that and showing us with the detail. The visuals really are something. And again, that's why you go to the right professionals to do these kinds of things. There are perfect ways with excellent results and not so perfect, I'm sure. How about, and I think one of you covered this too, for those who, to have one of these procedures, if someone already has an artificial mitral valve, to go in, I think one of you said valve on valve or valve to valve. Talk to us about that.
I think we can tackle this together, Nico. I think that Nico mentioned that, some people, so we need to understand first the term of long-term management of aortic valvular disease, right? Management of patients, that the more and more we have technologies and the more and more we know our health, and the more patients are living longer. Like in the US, the life expectancy is getting more and more. And we do know that sometimes patients that have some interventions when they're in their 60s, in their 70s, those might outlive the procedure. They might outlive the valve, the tissue valve that was placed to begin with. So these tissue valves, either the surgical valves, for example, or the TAVR valves, they have, unfortunately, we have a limitation in the technology, which is the durability of that valve going forward. We do know that it should last a decade or 10 to 12 years, but they will usually require, if you live longer than your valve, another intervention. And this is where we're talking about valve in valve. In the mitral space, it will be basically putting a valve from the groin into that space. And in the aortic side will be the same thing as Nico, Dr. Spilias mentioned, would be to put a valve in that old frame, and then giving the patient, again, 10 more, 12 or 15 more years of valve life as we go through, and we have been in this arena for a while, we have seen that valves have changed, and the way that they are engineering the valves and making better the leaflet. But so far, unfortunately, we don't have a valve that lasts forever. And we do need to, especially the tissue valves, we do need to change them once in a while. What do you think, Dr. Spilias?
Exactly. This is exactly right. So and that's what our priorities at the University of Miami. We look at what we call, the lifetime management of this aortic valve problem, because we get patients at different ages, like in their 60s, in their 70s, in their 80s. Now, if we think that the life expectancy, now the average is like 80 to 85 years, at University of Miami, we want to extend that. We really want to think about 90 years or more. So that's why the heart team approach we have at the University of Miami is very important. We sit down with the surgeons, we sit down with other cardiologists as a team, and we plan for this patient for their future, because we can always put a valve in now, but what's going to happen after 10 years? We need to think ahead. We need to be ahead of the game to make sure that the patient lives as long as they would live with if they didn't have the valve problem. So, for example, roughly the sort of like there's a cutoff like of 65 years old, 70 years old. If the person is younger than 65, maybe, or around that age, maybe, surgery is better. Surgical valve replacement is better as a first option, because they remove the old valve and they put a new one in. So 10 years, 12 years down the line, we can come when the person is like 75 or 80 years old, and we do the very minimally invasive procedure, which is the TAVR, inside that old valve. So that's why it's very important to have a team approach for these cases.
Yeah, that's interesting, and I think that we're living so long, and hopefully with good quality of life. But I almost parallel it to joint replacements, right? When you get a new knee or when you get a new hip, it's relative. If you're too young, you may need another one at some point. So we're talking about the same thing. The only difference here is that the heart is what keeps us alive, and knees not necessarily. Just a good comment from one of your attendees who said, "A great big thank you to all the doctors for not speaking so rapidly, especially with all these medical terms for us older people." So they really appreciate that. All right, here's a question about congenital heart disease. Do you still need to have open chest surgery to repair the aortic and mitral valves in this case?
Yeah, so adult congenital, again, is a very complex, unique specialty within cardiology. We have been seeing across the US certified centers of adult congenital disease. This is a population that's also will be growing older than before, because of the therapies that we have to keep them alive. So we have these patients that are going to be living longer thanks for the interventions that were done when they were kids, and now they're living longer. And again, these patients, they may require interventions in the future, which include aortic or mitral or tricuspid replacements. And definitely the technologies that we're talking about today are options to this population. If we have to do again a team approach where we discuss these patients in a multidisciplinary fashion, trying to gather all knowledge from all sides, including when we're talking about adult congenital patients, including the advice of the pediatric colleagues, because definitely this type of patients are unique and for the most part more complex than the bread and butter not acquired heart diseases. So yes, we can do them. We have done them in congenital heart diseases.
Okay. Here's someone who obviously has some expertise or has perhaps had some of these procedures, but what's the difference between TEER, TMVR for severe mitral valve regurgitation? Is one of these mitral clip?
Yeah, so TEER stands for Transcatheter Edge-to-Edge Repair, which is technically, it's another name for the mitral clip. So it's the same thing. So TEER mitral clip is the same thing. TMVR stands for Transcatheter Mitral Valve Replacement. So currently, transcatheter mitral valve replacement is not, let's say, it's under clinical trial. There are certain valves and new valves and devices that are under investigation and clinical trial for patients who are very, let's say, on the older side and very sick to undergo open heart surgery. TMVR, transcatheter mitral valve replacement, may be an option for them if the anatomy is appropriate, but this is usually, I would say, the exception. With the exception, if someone has already a surgical mitral valve in place and biologic valve that goes bad after like 10 or 12 years, then we can do a similar procedure to a TAVR to put a new valve inside the surgical mitral valve. But right now, the TMVR is mainly an investigational, like in the investigational stage. Okay.
Okay. Obviously, someone who had some inside the ropes kind of knowledge. I think I'm going to know the answer to this, but the two of you, if you would address this, do you think cardiac rehabilitation is helpful for patients with heart disease or after TAVR? I would guess so.
Yeah, I think we have it's very well established that cardiac rehabilitation is highly recommended in patients that have undergone any type of either a a coronary intervention or a valvular intervention. We recommend that to all our patients. We want them to go to cardiac rehab. We want them to participate. We want them to understand how the body feels and how can they better recover going forward after these procedures. So we do recommend, and actually we send and refer these patients to cardiac rehab, each one of them, every time they get discharged.
And that's also part of your multidisciplinary team approach. I'm assuming that that's all part of your program.
Absolutely, you're right. It's part of the program, and we actually before doing the procedure, during the discussion of whether this patient is a candidate or not a candidate, we actually discuss these type of things because this is fundamental to the recovery of the patient and the success of the operation. So as, for example, what's the patient's support at home, and the support and how many people he needs to be helped or not, but we need to be looking at the patient as a whole. So that's very important.
Is this something, stenosis of the arteries and all that affects more men than women? Because I know that it's always been controversial that we always used to think that heart disease was a man's disease. Not so much anymore. Where are we with the numbers?
This is actually absolutely right. The aortic valve disease and the valve disease in general affects both men and women equally beyond a certain age. And it's been recognized in the recent years, and we treat both men and women with valve disease, and I do not think there is a difference in how let's say men have the same, let's say, frequency of valve disease as women. So I don't know what Dr. Cox's experience and impression is on that.
Yeah, I think yes, I agree with Dr. Spilias. There seems not to be a difference. What we do know is that women live longer. Huh? So definitely, as they do, we're going to be seeing more of that woman with issue with the valve. The other thing that's very interesting, not gender related but race related, and I want you to click here for a second, because we do know that this therapy work. regardless of gender, right? And regardless of race. But we do know that our community here in South Florida, for example, the minorities, people of color, Hispanics, we do have seen that they don't get the procedures, these therapies, as much as our other the other Caucasian population. So that we know that there is an issue of disparity here that we do need to dive into at some, what we are diving into for sure in University of Miami, but we do need to dive into in the US to see why is it that Hispanics and minorities are getting less of this procedure than our counterparts, and see how we can diminish that bridge, because definitely therapy work regardless of gender and regardless of age. And we need to get a better understanding of that. Maybe we need to do a better job helping understand our patients, trust us, maybe, that these therapies work and that they need help. Maybe our communities are more skeptical of looking for help and being sure that this is the right thing to do, and maybe we need to do more more explanation on this.
Yeah, and I think access is the key. And what Dr. Chatzizisis said at the beginning about the way we've spread out UHealth in the communities, we have Doral now. Well, of course, there's a predominance of Hispanics in Doral, the Sole, etc. So there's a lot of centers. But yeah, it's outreach and education and so forth. We have 4 minutes left.
Yeah.
So I know, Dr. Spilias, if you want to kick off and give us a closing message, and then Dr. Cox will follow before we say goodnight. This is flow. We had so much to cover.
I saw just a quick question from the public. Again, can lifestyle changes reduce the need for TAVR? So in general, TAVR is like, sorry, the aortic stenosis is a sort of like process of degeneration of the valve with the aging, with time. There are certain factors that accelerate this process. There are some signals, some signs that high cholesterol or whatever is causing high cholesterol can also cause calcifications on the aortic valve. And also, for example, people with kidney disease tend to have more calcification of the aortic valve. So I would say doing whatever is considered healthy for the heart in general, meaning like healthy diet, watching your cholesterol, watching, your blood pressure, your blood sugar. This will hopefully, let's say, delay that process of the calcification and degeneration of the aortic valve. So now, regarding the closing statement, I would like to thank again everyone for putting this together, and for the audience for attending this webinar this evening. And I just want to say that we have a great team at the University of Miami, and a great heart team, and we treat every patient as if they are family members, family member of ours, and we prioritize every patient, every patient's needs, and we plan for them, and we make sure they get the best possible outcome. If you have any concerns, any questions about your heart health, please, call the number and ask, to have an appointment with us, and we guarantee you that, you will get the best possible care for your heart, and the right treatment.
Thank you, Dr. Spilias, and Dr. Cox, you're next, but I want to remind the audience that as soon as I put up that final screen, they're going to get to see the number again and so forth, so you can reach out and get appointments. Go ahead, Dr. Cox, just take us home. We have a minute left.
Okay, again, thank you everybody for logging in. We're happy to be here tonight discussing this available therapies in University of Miami. Our goal is to provide, again, exceptional care without exception. We are here to help you tackle your disease, to help you find solutions for these complex problems in a multi-professional, multidisciplinary fashion. Our goal is to help you through quality, excellence of care, and we're here to help you to the end. thank you so much. And thank you for logging in and joining us tonight.
Thank you both so very much for the privilege of your time. It really is an honor. Thank you for being with us tonight. And to you, the audience, thank you for hanging in with us and for being so interactive. There you go on your screen is the information, because the program has ended, but you can contact our UHealth cardiac and vascular experts, umiamihealth.org/cardiovascular. There are your appointment number, 305-243-5554. And please do the survey at the end of this talk so that you can give us some feedback. We appreciate you all. Stay healthy out there, everyone. Have a great and safe night.
Have a good night, everyone.
God bless.